All right, well, good morning again. We're pleased to get our first and the most exciting session started. I will introduce to you our speakers, and I won't read their bios. The booklets are being handed out to you now, and so you can certainly take a moment to do that, and I would advise all the students to certainly read the bios of each of our speakers. Our first speaker in this session is Dr. Torian Easterling, the Senior Vice President for Population and Community Health and the Chief Strategic and Innovation Officer at One Brooklyn Health. Dr. Easterling's topic is Advancing Justice, Historical Roots, and Future Solutions for Health Equity. Following Dr. Easterling, Dr. Marverine Beverly will speak to us. She is a patient engagement and cultural competence specialist, and her topic is patient engagement and cultural competence, the roadmap to achieve health equity. And though those two speakers are certainly great, the next two are near and dear to my heart, and so I have to give a special welcome to them and a special introduction to them. They have been very supportive of each other, of women at Howard, of women in the Black community, and women globally. The first is Karen Roberts Turner. She's a Senior Associate General Counsel for Health Sciences and Adjunct Assistant Professor of Ethics at Howard University. Attorney Karen's topic is ethical decision-making in diverse populations. And just on a tiny, tiny personal note, I know, Dr. Salafu, you said to be brief, but I have a hard time following directions. She is just the kindest person. She makes sure that you're well taken care of in her field. I first met Karen. She was sitting at a table leading a group of very, very distinguished and accomplished attorneys, physicians at Howard University. But I was so proud to know that she was there and then to get to know her after that because of the way that she was able to manage that group and how she's managed her career. So she's just a wonderful person. After that, we have Ms. Brenda D. McDonald, RN, and all the other letters after her name. She's the Clinical Risk Advisor, National Healthcare Practice at Aon, and a forever Howard University employee, ma'am, just so that you know that. The title of her talk is The Cost of Getting It Wrong. And I'll tell you, the first time I came to Brooklyn and to meet with Noah New York and Henry Paul, it was Miss Brenda Douglas McDonald who accompanied me. She assisted Howard in getting the affiliation with Noah New York, now Medinova, and she is a stalwart. Now, Karen, she'll pick you up and rub you and make sure you're okay. Brenda's gonna bowl you over and then check back a little bit later and make sure everything's okay. But just another support for women, professional women, always supportive of Howard University, supportive of our students, and I'm so pleased that you too have joined us here today. With that, you told me to be brief, so I spent all my time on these two. Dr. Easterling.
Good morning, everyone. What an honor to be here. Congratulations to all of the lead faculty members and the planning committee members for this occasion. I just want to make sure that I know what I'm doing. Great. Okay. I have my slides in front of me. Once again, as you've already heard from Dr. McDonald Pinkett, my name is Torian Easterling. I'm a family physician. I formerly served at the New York City Health Department, and so you'll see some familiar slides and familiar information which I presented before, but I will not stand before you long. Sometimes I don't follow directions, but I'm going to do so this morning because we do have a really august group that I have a chance to be a part of on this panel, and I want to make sure that they have their due time as well. One of the things that I think has been really, really important for some of the work that I've been doing is really making sure that we're naming some of those issues that we're talking about, and really being bold in a way that we're not just sort of passing by it and making sure that we give language to the issues and the challenges. And given that we do have folks who are online, you'll see in some of the earlier slides, there are a lot of contextual things that I'm talking about here in New York City. But I do think that these are cross-cutting issues that we're facing not only in New York City, but around the world. And as you've heard from Dr. Salafu, an example of how community organizing, both from an academic standpoint, from policy standpoint, from union and labor, what real change can look like for us to hear the announcement about $1.1 billion being dedicated to a hospital that was not fought by just one group or one individual or one institution. It really takes collective action. And that's essentially the message. And so if you tune out, you got my message for today. This is going to take collective action. It's going to be cross-cutting, and it's going to have to be bold. I have nothing to report or disclose at this time, and you have some of my, well, you may, I don't know if it's in the booklet, but I have shared my purpose and objectives here, gaining a deeper understanding of the systemic challenges for health and healthcare delivery, discovering actionable strategies to advance equity in your organization, and being really clear that we're not just talking about health. If we are going to see the type of change, we're going to have to make these changes in all of the sectors that intersect with not only health, but education, and housing, and transportation, and that is the work. And so as we move forward in thinking about how we curate these conversations and the spaces that we're sitting in, we need to make sure that the person that is sitting next to you doesn't just have the MD or the RN or the LPN, but we're also thinking about the cultural strategist, the content creator, and the educator, all the different people who are in the communities that we are talking about today. And so I will not belabor the point in going through all of the objectives. As I was just rambling, I'm sure that many of you were reading. And so in my brief agenda, I'm just going to be unpacking, as I mentioned, some of the context of the inequities that we're seeing here in New York City. And so for those who are not really versed with New York City, and as you heard from Dr. McDonald-Pinkett, it is different here, and it's certainly different here. But I think that there are threads that we must pull on to make sure that we understand that we're all a part of this human connection, and we're facing similar challenges. How do we build capacity for action? How do we then think about what reimagining health looks like? And I'm going to try to do all of that in now the 5 minutes I have left. So the way I'm going to sort of talk about this context, I'm going to just talk to you about some of the work that was happening in 2021. I'm not going to go back to 2020, as many people will remember in 2020, the fight to really raise the consciousness around what we were always talking about when we were talking about structural racism and health equity and health inequities. And really, because of the murder of George Floyd, it put the inequities that we saw not only in COVID-19, but really the reckoning with racism in this country front and center. And so as a result of this racial reckoning, the New York City Health Department passed a resolution in October of 2021. In that resolution, we not only declared racism as a public health crisis, but we also outlined 9 commitments that the health department would undertake to advance its anti-racism work in New York City. This was a really seminal legislation piece of work that was passed to ensure that not only the health department would be able to do its work, but that it would be able to work across agencies, transportation and education, corrections, and others, police department, to really use data in a really intentional way to think about how we were using funding, as well as how we can advance and push forward policy to continue to advance our anti-racism work. But what was really important, and if you have a chance to look at this this resolution, was really some of the language that we made sure to include in this resolution. One, we wanted to make sure that folks understood that what we were talking about, and we were super clear that we were talking about structural racism. We weren't just talking about interpersonal racism or institutionalized racism. We were talking about structural racism. And the reason why structural racism becomes really important, I want to make that distinction that often institutional racism is the focus, or interpersonal racism is the focus of papers and articles, and oftentimes it is also the focus of organizational strategies. But when we're talking about structural racism, we're talking about the societal, the ideological frameworks that are used, those systems and practices that are shared, not only by your institution, but other institutions as well. That's what I contend, and what others, I would say, contend is the work that we must do. By naming structural racism, we are naming that it is not just our institution that is perpetuating these biases and these discriminations. There are multiple factors at play. And here in New York City, we have seen how these policies have come to fruition. As you can see in the upper right-hand corner, left-hand corner, transit, expressways and crossways moving in and pushing through Black and brown communities. And we have seen, as a result of those decisions and those policies, the outcomes for not only health, but also economic deprivation, also community development deprivation as well. And then even also moving into housing, moving into criminal justice. And so you get the point of how these policies can really perpetuate discrimination and bias in communities, and not just any communities. We're talking about Black and brown communities. We're talking about indigenous communities and other people of color. And that is what I think we have to be clear about. And we're talking about structural racism, that these practices show up not only within healthcare, that they also show up in other sectors as well. And so we wanted to make sure that in our resolution that we name that structural racism is the issue, is the original sin that we are focused on, and that these 9 commitments were really outlined and designed in a way that this wasn't the work of the health department alone. And so as we're sort of thinking about how we can not only impact and advance health equity globally, I think it's for us to sort of think about what the internal work of organizations look like, acknowledging the harm, repairing some of the work that we've already done, and then moving past our 4 walls to think about how we are doing cross-cutting work and how we're connecting with different institutions and sectors to bring about change within the community that we serve. And so that, I think, is the call to action for many of us. And so as a result of these policies that we have seen in transportation, and I'm sure other speakers will talk about how redlining has also led to the impact of what we're seeing in these maps here. And so as a result of what structural racism has done, we're looking at many of these, the impact, and not only in health, but we're also looking at it from life expectancy and the outcomes that we care most about. Many of you all care most about, whether it is here in New York City or the communities that you serve in as well. Whether you are in south side of Chicago or you are in Southeast DC, you can overlay the maps of your communities, and you may find many of the same patterns, I'm sure of it. And so as we look at these 3 maps that are in front of you, from left to right, making sure that we sort of see where Black and brown communities are most concentrated across New York City, whether you're looking at East and Central Brooklyn, where you are right now, or you're looking at the South Bronx, or you're looking at Northern Manhattan, or parts of Staten Island, parts of Queens as well, where the higher concentrations of Black, Indigenous, and people of color are in New York City. You also see the patterns of life expectancy or lower life expectancy. You also see the patterns of higher preterm births. Now, if I was also to look at jail incarceration rate or higher non-fatal assault hospitalizations due to violent injuries, or we were looking at cardiovascular disease, chronic disease outcomes, cancer outcomes, what do you think that those patterns will all look like when we're talking about the worst rates? Would they align with these maps that you're already seeing in front of you? Oh, come on now. I know it's early. I know it's early. And I tried to make sure the volume in the microphone is working. But I think that you all are with me and are following with me, that the information and the patterns will certainly track with other outcomes, whether we're thinking about social or environmental or other health outcomes. And so using data to really make sure that we're showing the injustices is the work of ensuring that we're doing our anti-racism work. This isn't always easy to be able to uplift it, and then also think about what those actionable strategies are, right? And so it is a huge step for government to be able to own some of its own failings. By one, not even saying that we have disaggregated the data in a way that we're intentional in showing where we have neglected and disinvested in our resources, and also we have perpetuated discrimination and bias in those same communities. It is really important that government takes that step, because I think it would also role model for other organizations, both in the private sector as well as the public, to ensure that they are also following suit as well. Where are your resources going? How are you engaging with partners? How are you ensuring that your resources are really prioritizing, not just targeting, prioritizing the most neglected, those who are most marginalized, those voices who we keep saying that we want to uplift? Are we actually connecting with them? Are we actually engaging them in the way that they will be benefiting from our services? And so understanding how structural racism plays out, not only in our own practice, but also in the practices of the institutions and the organizations that we work with, and then being able to reflect that in the information that we are sharing. Because data is going to help us understand whether what we're saying and whether we're putting our money where our mouth is. So here, just to get a little bit more hyper-local, I know that we are not in Brownsville, but we are in East Flatbush. But we, right now, as we're thinking about our service area for our institution, there are approximately 1.25 million people who live in our catchment area. East Flatbush is certainly one of them, stretching all the way to Canarsie, Midwood, coming back to Brownsville and East New York, Bedford-Stuyvesant, Crown Heights. For those who are familiar with the borough of Brooklyn or the planet of Brooklyn, those neighborhoods sound familiar. For those who do not, let me just say it another way. You think about where Biggie or Jay-Z lived, or you think about where Little Caribbean or Little Haiti might be. These are the neighborhoods that we are very much focused on. And so when we're looking at the data, we see similar outcomes when it relates to premature mortality, as I just shared with you, preterm birth rates. And so when we're thinking about life expectancy and premature mortality, one, we also understand that there is a bit of bias even in the data that we're looking at, because oftentimes, and we also struggled with this when I was at the health department, the reference population is not always the reference population that you want to use, meaning that we want to make sure that we're not just looking at the white population as our reference population. As you see in the previous slide, We're even naming a non-white population as reference for you to understand how we began to disaggregate the data instead of thinking about Black and Indigenous and people of color. And so understanding even some of the limitations in our data, but it still helps us in really understanding where we need to prioritize our resources. And certainly Brownsville, when we're thinking about some of the demographics of the population, when we're thinking about the social and economic conditions of a neighborhood like Brownsville that has less than 100,000 residents who live within a 2 zip code area. But why do we see some of the worst rates in this one area? And those are the questions that we often try to wrestle with and really try to think about how we can direct our services, and then who do we partner with? Who do we engage with? Who do we ensure that those individuals understand what resources are available to them, but how do we disseminate it in the way that folks can really participate and trust in those resources and understand that it is for them? And so the problem, I would say, that we're trying to solve is not trying to make sure that all of you understand what the vision is. It's really making sure that we can build the trust to able to execute the vision. That's the problem. And oftentimes we create the documents, and there are more documents that are being created, and healthcare institutions have an opportunity to really be able to repair the trust, the damage that has been done, the mistrust that has been placed within the communities because of the lack of work that we have done in the past. There's a lot of work that we must do to repair trust from Black and brown communities, for them to ensure that they see these institutions as their institutions, as they are being more civically engaged in the management and the decision-making and the outcomes of what these institutions are going to look like. And so again, I reference this process that over a year and a half, where the University Hospital of Downstate, the future of it is at stake. This room was filled to the brim. Folks were engaged in the planning and the discussion and wanting to see that the vitality of this institution the status quo was not going to remain, but something better was going to emerge. And now we have that next step. But what does the next step look like? And that is what I contend is most important. In 2016, there was also a process for the hospital and the health system that I worked at, where community and labor, clergy, policymakers came together to come out with a vision that really talked about improving the clinical quality outcomes for the system, ensuring that the population health needs were going to be met, to ensure that an institution in the system was going to be charged with also the economic vitality of the communities that it served. All of those words sound great. But what is at stake is really making sure that community sees itself not just as the recipients of those services, but really as part of the design and the execution and the implementation of what the vision is going to be. And that is part of the work that I've been helping to lead at One Brooklyn Health, ensuring that we're bringing community closer to this institution that sees itself as an anchor institution, strategically partnering with organizations as we design new interventions that align closely with the system's priorities, but also to really think about what is our role in also being an economic engine for this community as well. If we are not meeting the social needs of our community, then it is really hard for those who are delivering the clinical care that is much needed. As you've heard, cardiovascular disease, cancer continues to be the leading causes of morbidity and mortality for our communities. And so if we are going to make headways in really addressing those outcomes, it is going to be important for us to also think about all the other outcomes that are most important to our communities as well. And so in 2016, as I talked about sort of this formation of a new system that focused on clinical quality outcomes, that also focused on population health needs, that also focused on revitalizing the economic well-being of the community. Also at the bedrock of it was also this advancing a health equity strategy within the system. And so a lot of that was led and started within our clinical quality team, really beginning to outline different projects around cardiovascular outcomes, around social determinants of health, and being able to not only identify but address those social determinants of health. And I'll talk a little bit about our Food is Medicine project. But then also beginning to look at health literacy as well. And so there were a few projects that the clinical quality team began to focus on, working with departments across the system. And what we have seen is that this was also sort of an engagement in the education process for leaders across the system as well. And I think that that's really what we learned through this entire engagement is how much there was a variability about what people knew about what health equity even meant, and what the role of system leaders and department heads, what their role were in really making sure that they were participating in advancing that strategy as well. And so as we began to retool in 2021, we began to really think about, well, what is our responsibility to both educate not only our patients, but educate our staff and our leaders to ensure what their role is, and to really think about what that engagement process was going to look like across the system. So we designed town halls, we designed surveys, we designed trainings to not only for our department leaders, but also for our residents, to really begin to have conversations around advancing health equity as a system, and really being able to get granular in the work within the departments of how you design a health equity improvement project to meet the type of quality targets that we need to see, particularly for the populations that are most marginalized. And that has really allowed us to fully understand what type of tools need to be designed for certain care models, for us to think about innovation as well in our clinical care models, and to think about who we need to strategically partner with as well to really enhance the type of care models that we need for our patients. And I think those are the steps, and I think those are also going to be some of the themes that you'll be hearing throughout the day as well. So as you saw in the previous slide, as we began to really design our own ways of addressing social determinants of health across the system, we have since standardized the way that we screen all of our patients across the system around addressing social determinants of health. And one of the social risk issues that continued to come up for us was food insecurity. And our former CEO gave me the task to begin to design a lifestyle medicine program for our system. And really the goal was to improve the way that we were not only thinking about the well-being of our patients, but also for our staff as well. And so we began to partner with organizations such as Grow NYC, Cultivating Justice, Isabel Ladies of Elegance, to really think about how we can not only address food insecurity, but also strengthen our local food systems within our communities as well. And another way of thinking about that is that we have growers and aggregators right here in Brooklyn. We have farms that are within a 100-mile radius of our health system. And how are we partnering with those growers and aggregators to bring food and ensure that the community understands how those food systems can really improve their own well-being? And we're not needing to go so far away or to source food from other states, but really thinking about what's in our own backyard. And so there were a number of different things that we took on, educating our staff about lifestyle medicine and food as medicine, through a training with the American College of Lifestyle Medicine, starting a community-supported agriculture food box program for staff and also patients as well. We subsidize the food box for our patients, increasing access, particularly for our ambulatory care patients, which was referred from our ambulatory care providers. But then also working with local growers in Brooklyn, in Central and East Brooklyn, to make sure that we were sourcing and then also educating and doing nutrition education for our community members as well. And so we are continuing this program in 2025. We're now expanding the program, working with a local grower right here in Brooklyn who has multiple farms in East New York, as well as in Brownsville, sourcing food from Brooklyn, but also from New Jersey and Pennsylvania. And now we have 2 providers who are going to be looking to start their own lifestyle medicine practice as a pilot. And so these are the conversations that really started with what we're seeing in our data and moving to, well, let's then pilot a food box program that will really allow us to think about how we are engaging our patients and addressing a specific issue that we're seeing in our diet, and then having a different conversation with our providers. Another major issue that we continue to see in our data, and particularly in East and Central Brooklyn, is community violence. I know workplace violence is also an important issue as well, and so I don't want to minimize, but I think when we're thinking about community violence, I think there are many forms of violence that we want to address. And certainly community violence, when we look at our non-fatal hospitalization rate, we have the second highest rate of non-fatal hospital assault due to violence coming into our emergency room. Kings County, which is just around the corner, across the street, also has a high volume as well. And so in 2023, we retooled and rebranded our hospital-based violence intervention program by bringing in our local cure violence partners or crisis management systems. Depending on where you are in this world, these could be violence interrupters. These could be credible messengers, but they go by many names, or community health workers, to ensure that we were doing 3 things. 1, we were providing crisis management in the time of troubling need for someone who was coming in with a violent injury. 2, we were providing wraparound services for individuals as they were being discharged. And then we were partnering with individuals to really think about the root causes of community violence so that we can really stem the tide of this revolving door of violence that we're seeing in our community. And so now we are moving into the 3rd year of this retooling that we're doing for our program. Last year, we saw over 3,000 cases. Those are not unique cases. We have about a 10 to 15% re-injury rate among the populations that are showing up in our ED. And so there is an opportunity to not only address the community violence that is coming into our ED, but also to reduce the re-injury rate among those who are presenting. And we are seeing intersections, obviously, of domestic violence, of substance abuse, of homelessness among the patients who are showing up. And it really requires us to be strategic about the type of partnerships that we have to ensure that we're addressing what is presenting in our emergency department. And so we're currently being funded. Grateful to say that in this most recent budget approval by the state, that there will be additional dollars to hospitals to really expand their hospital-based violence intervention program. And as we think about sustainability, we are also looking at ways that we can use Medicaid reimbursement as well to sustain the program. And that was actually passed in 2024 in New York State through the state plan amendment to allow hospitals to use Medicaid dollars to also fund their hospital-based violence intervention program. Here are just a smattering of other examples and the ways in which we are trying to work in advance and build capacity towards action in advancing health equity. And just to name a few, because I know my time is short, really thinking about how we're utilizing patient voices to drive transformation, to drive change. We're really looking at ways that we can use patient experience surveys through a partnership with Narrative Nation, really to support mothers who are, or pregnant persons who are birthing at our institution, but also a patient experience survey that was designed in collaboration with this esteemed institution, as well as Arthur Ashe Institute for Urban Health. And so using the Brooklyn Health Equity Index, we are now using that information from patient surveys to then think about how our quality improvement projects can be enhanced as well. And so we were the first institution to actually roll out this survey. There is now ongoing work to now expand this to other institutions, including University Hospital at Downstate, to name just one other. We have since launched a community advisory board, thinking about foster meaningful engagement with our community partners. And also what I'm really, really excited about is a new initiative where we're using art in a way to tell stories, to really uplift voices of our community, to really begin to design transformation and bring those voices into our system as well. And then lastly, what I'll just say as I started is it's really going to take collective action for us to reimagine health in this next chapter. And health isn't really just thinking about the outcomes, that our own individual outcomes that we may have, but really to think about our well-being, our vitality of what our community is going to look like. It's going to really think about the type of data that we're going to need to be able to tell the stories, but to make sure that we are unearthing the uncomfortableness of what we know to be true in our communities. It's going to be thinking about the different tools, yes, in our care models, but the tools that we will need to ensure that folks will remain at the table, and also can be very engaged, and also to be in a way that folks can fully immerse themselves in that process. And oftentimes those tools do not allow, if they're very academic and oriented, if they are very healthcare oriented, it does not allow, or disallows other groups to be fully engaged in that process. It's going to think about different ways that we can use communication. Yes, social media is really important, but also thinking about ways that we are coming back into spaces where folks can feel like they are getting updates and there's transparency, and there are opportunities for folks to also lift up their displeasure with the process. There is an opportunity for institutions, whether you are an academic institution or hospital, or whether you are a banking institution, to see yourself as the backbone support to really help drive the change. This will require resources that we know that the federal government is trying to take away. And so to be intentional in how this work does not go away is to think about what resources can you share, whether that is going to be an actuary role, or you're thinking about someone who is going to be data mining, or whether you're thinking about a researcher, someone who can be contributive in the way that can help sustain the planning, the coordination, and oftentimes just to make sure that we are putting notes together and so folks are getting updates. And also, ultimately, it's the agenda, right? It's making sure that we're really clear about where we want to go. And designing this vision for health and wellness requires us to be bold and be courageous in this next moment. And so I thank you all for your time and for your attention, and I will cede the floor to Dr. Pepper.